Hi, I'm Daniel Nyman. On behalf of the Forum for Healthcare Strategists, as well as our partners at Healthgrades, welcome and thank you for joining us for today's webinar, Overcoming the Hype, an Innovative Approach to Provider Alignment Strategy. Today, provider alignment is not something healthcare organizations can set and forget. Instead, success requires an innovative approach incorporating market intelligence, data management, and smart investments in technology. To help us tackle the topic, we have two terrific speakers. Elowsky, Physician Relationship Management Technology Manager at Henry Ford Health System, and Keri, Braley, Associate Vice President of Provider Strategy at Healthgrades. A couple of notes before we begin. Attendees are participating in listen-only mode, but you can still ask questions. If you have a question, please enter it into the question and answer pane located on the bottom of your screen at any time. Our speakers will respond to as many questions as they can in the time we have. We'll also be conducting some interactive polls during the webinar. Be sure to participate by clicking on the answer that best reflects your views. With that, I'll turn the program over to Keri Braley. Keri?
Great, thank you so much, Daniel. And thank you all for carving out an hour to join us today. We have a really thoughtful discussion planned out for everyone where we're going to really take some time to dissect the best approach to a provider alignment strategy and put it to best use. So why do we talk about the need to sort of overcome the hype, as the title says? So, when we think about this, there really is no magic bullet for provider growth and alignment strategies. There are a large number of factors that need to be examined. Where is there true opportunity? Is it going to be worth it to my organization? Are we operationally ready to grow? That's always a crucial question to ask. And then what are the goals? And of course, the big question, where do we start, right? So that's what we're going to go ahead and do. We're going to take on that challenge today. I'll be starting out with a discussion on all of these factors that do go into a really well thought out plan. And then my partner, Abby, will be showing us all how we put this to good use. So with that, let's get started. So let's start with the fundamental question of why does the modern health system need a physician relationship management tool, or a PRM, as most have come to know it. So hospitals and health systems today have really spent a lot of time and money to build out networks of employed and affiliated and in some other way aligned physicians to the organization. So they want to make sure that obviously those providers are loyal, engaged, involved, but also having their voices being heard. So there are other market providers that may not be directly affiliated. And of course, based on opportunity and what's known in market intel and resources, those relationships really need to be developed as well. So to do this, it really takes both a structured relationship building plan and of course, a very well thought out team that is able to execute on that. And of course, market insights. And now that's really more important than ever. And what we talk about here is that members of the baby boom generation that are born somewhere between 1946 and 64 began aging into Medicare in 2011 at a rate of approximately 10,000 people a day, which is pretty staggering. And that rate will continue into 2030 as it's predicted now. And in fact, over the next 15 years, Medicare's enrollment is projected to increase almost 50%, rising from 54 million beneficiaries today to more than 80 million in 2030. And this trend, what's happening is it's starting to erode a health system's most profitable patients, all while the system leaders are pressuring you as outreach folks or planners and business development people to find new avenues for growth. And two undisputed growth avenues are, the modernized direct-to-consumer acquisition, of course, and engagement strategies, but also changing provider practicing and referring behavior. Health systems are also continuously adapting business development efforts. One real example is the role of liaisons now, and certainly now more than ever with COVID impacting all of our operational sort of original plans that we set out for. So this could be with consumer audience. Area employers is another very common one. Support staff is certainly somewhere that liaisons tend to focus quite a bit of their time as well. And so health systems need a tool that's really flexible and scalable. And that's really what we're here today to discuss. And we know the critical advantage to having these insights aligned with a tool and a great team to align them, to aid in this journey. With that, I think we're going to go ahead and throw our first poll out to the audience. So how confident are you with your organization's PRM tool? And we've got a few options there. Very, somewhat, could use a little bit of work. the true help, we don't know what we're doing, or we don't have a PRM at all. So if you can take a moment to help us out so we get an idea of where everyone's at, that would be great. And I think we'll just give it a couple more seconds here. And there are all results. Thank you so much for responding. So looks like about the majority of folks, and not surprisingly at all, fall into that somewhat could use some work. So we're always looking for ways to improve, to grow our claims analytics, of course. So it sounds like most have some sort of a system, but know that it could use some refinement. And there are a good number of people also that fall into that very. And then, of course, it looks like a quarter of the folks who responded don't have a PRM system at all. So hopefully this presentation will give you some ideas of where to go next. So you'll see what we've done here is we've laid out what we feel is sort of a best in market or best practice approach to this sort of continuum going from left to right, starting with that market analytics, the market intelligence phase, and progressing all the way through informed provider outreach all the way to the right. And we say highly engaged because we know that there are so many moving parts, right? So there is no one perfect provider directory in existence. We'll definitely talk about that quite a bit in this conversation. So taking a comprehensive approach to building this part out as sort of the fundamental foundation of where you're going to start is going to be critical. And later on, Abby will be digging into this topic even more because this is near and dear to her heart. And she'll make it clear how this is benefiting not only her team, but the organization as a whole. So definitely an important piece. So it starts with that comprehensive, as clean as possible provider directory, right? We deliver both broad and specific intelligence when it comes to market analytics. And all the expected business development workflows need to be built into an easy to use tool. And don't forget, it's also essential. We talk about that targeted campaigns in the second to last block there. It's so critical to make sure that you're aligning the provider outreach initiatives with whatever's happening on your consumer marketing side as well. And then, of course, ultimately, we need this to be tracked. It needs to be easily tracked and easily reported on so that we can really show the organization the ongoing impact. Do we need to make changes to our approaches and tactics? And really, ultimately, of course, always driving toward patient retention and growth. So first, we talk about the users should have an option to import provider data from a variety of sources. So those could include API feeds from their website, batch processes, CSVs, other listing vendors. We know that it takes more than just one source to pull together a really comprehensive and accurate provider directory. And needless to say, also, we need them to be able to manually update a provider record as well. And we'll talk a little bit about that in the future slides as well. So a key component of this, of course, is that provider directory. It really makes sure also that all market claims can be attached to the provider. So some of the things that we do here, obviously, we look into things like the NPI registry or the NPES. Physician Compare is another example. But we also, what we like to do is make sure that we're able to match up those claims analytics that are coming in through our clearinghouses and matched up, of course, by NPI so that we're ensuring accuracy of data. And we're able to tie together specialties, especially if a provider has multiple specialties. We want to make sure that that part is accurate. Their locations, always a difficult thing to pinpoint. And we know that providers have multiple locations and sometimes even moonlight at certain different competitor locations as well. So all of that information is critical. But as we know, it's never perfect, and the folks who are out on the road are certainly the ones to hear some of this information firsthand. So having that tool that you're able to come back to and real-time update it is of utmost importance. So Abby, I know that you are all too familiar with the growing pains of this clean provider directory, especially as you are preparing to move into our new optimized version of this platform. So maybe you can let us know what have been some of those biggest challenges, but also why is it so important and even now more than ever?
Yes. Thank you, Keri. It is incredibly important. And unfortunately, it took the COVID pandemic to show us the urgency of needing a sound provider source of truth, and especially in one location. When COVID-19 came to Michigan, our first case being reported on March 10th, Henry Ford Hospital in Detroit had already been in planning for the event for COVID. However, none of us realized, of course, the depth and the scope of the pandemic at the time, and we grossly underestimated its impact on our community. We found that many leaders were in need of data urgently, provider information and location information. Many of our teams ended up coming to our PRM team and saying, hey, we need this information, where can we get this? At the time, we had a lot of information, but not all of it. And it took a lot of time and a lot of scrubbing to find all the other areas of our system that had these bits and pieces of the information that was needed. We wasted some time and we wasted energy. And of course, time and energy is money doing this work. Hindsight being 2020, literally 2020, right? We quickly realized that this was going to be a top priority once we came out of the pandemic. Another thing we learned that I wanted to touch on is that through this process, while data is incredibly important, and during a crisis, data becomes even more important and very heightened, the people relationships are just as important and truly part of the engine that make this whole thing work. Our outreach liaisons were key in communicating information to our providers and their teams during a very scary time. And having that contact information and the activity logging that our outreach team did right at their fingertips during the early surge, and then unfortunately our second surge in the fall, was incredibly valuable to all of us. And that information really, really helped.
That's great. Thank you so much, Abby, for sharing that. I know that it's been an ongoing iterative challenge, but certainly one that's worthwhile, as you've proven here. So next, I just wanted to talk a little bit about how you can really enhance this provider profile with even more additional information. And when Abby talks to us later about her orthopedics example, you'll see here that taking in, certainly knowing their education, their affiliation, obviously their primary specialty, but now we start to get down to, especially during the pandemic and being able to open up elective surgeries and things like that, it's really so critical to know even more detail, things like what are some of the conditions treated, what are some of the procedures that this provider performs versus someone else that's in the market. So those are all moving parts that we want to keep in the forefront as well. And, like I said before, for having a record that is, able to be updated real time, so that while you're in the field, if someone's back at the, at the main hospital that you're working for, and they're able to see these updates real time, that's so important. And also for your own sanity, for the next time you go out to visit this provider, making sure you're going to the right place, but then also, as Abby mentioned, for the organization, becoming that true source of truth is a pretty powerful thing. So I wanted to touch very briefly, not getting too into the weeds with this part, but just briefly on the importance of understanding the second sort of big component to this strategy, which is the claims data. It's important to know generally, where does it come from? How is it sourced? What are we expected to be able to extract from it? And that's another area that, of course, is not perfect. We can never get our hands on 100% of the claims that are out there in the system. We have certain claims claims clearinghouses that we work with that ingest and are able to package up analytics from most payers, but there are some payers that don't really play well in this space either. So we know that it's never going to be 100%. But what you're going to see here is just the two main sources that we look at through the clearinghouses, multiple different payers, and then the CMS data, which, although lagged, really contains quite a bit of useful information for us as well. And then what we've done here is we've done sort of a master de-identification process. So in order for us to get our hands on this many claims, we have to have it de-identified. So patient protected, de-identified. But what we've come up with is a way to tokenize this so that we're really tracking that true patient journey from a PCP through specialist and potentially back to PCPs and imaging and surgical and everything else in between, really. And then applied to that is, multiple facets of data science. So we look at, being able to pull in the accurate site of service. We know that for a surgeon, especially, for example, they may have a practice where they're seeing outpatient clinic patients, but then also, of course, performing surgeries potentially at more than one hospital, right? So they may have credentials at multiple hospitals. So knowing what those accurate sites of service, truly where are encounters being performed versus where is the home base of the provider. And then of course, we try to layer on as much patient information as we can, like I said, without still keeping it de-identified. So we know that patients seek care potentially in their own area, but depending on what type of a metro area it is, they could be seeking certain services, especially subspecialties in a certain zip code area around your main market area. So taking into account not just what's in your general, primary service area, but secondary or potentially even tertiary in terms of where patients are seeking care. And then applying some case logic is so important too. So we don't want to look at just volumes of what's happening across different service lines and different specialties, but also referrals. And where are we seeing trends of those referrals, and making sure that we use a system as an early warning system as well, so that we know, certainly you can hear rumblings of leakage happening, but being able to have a good source of data to know exactly where this is happening and at what rate, so that you can really get out ahead of it as much as possible. And what are the real uses for this? As I mentioned, of course, leakage, reducing that outpatient migration, really accurate referral information, and then identification of any worthwhile growth opportunities. Is there a place that we ought to be working with our recruitment staff within our organization to be expanding into service areas that really are in desperate need of a new orthopedic surgeon, for example? Are there facilities that we ought to be considering building and expanding? So using all of this data, but curating it the way that we're showing here really tends to align the disparate data sources and then also clear up some gaps. One of those gaps, of course, I think, Abby, you've definitely been exposed to this too, is looking at when claims come in, knowing truly what's a billing entity versus an actual site of service for encounters. That can make you sort of chase your tail until you're able to curate that and identify which is which. So really, what does this look like? This is just an example of how we pull all of this together for a usable tool for someone who is out in the field. And Abby, of course, this looks familiar to you, but pulling in all of the information from that optimized provider directory, having those intuitive outreach workflow tools built right in, so that when you're on a provider record, you're able to see a couple of quick snapshots of what's happening with their referral patterns, where are they located, of course, how can I contact them, what is their opportunity? So, what we've done here is we've developed what we call a provider opportunity score, so that we can look at, when was the last time this provider was visited? What were some of the issues they may have brought up? And are we seeing any leakage or growth in certain areas that we can, cultivate that growth and certainly turn things around? So to summarize, it's really essential to synthesize the approach of all of this, okay? So we start, with the true vision from both the provider network and the consumer and patient perspective, as I mentioned, which really fuels the strategy. And tactics needed to be decided upon, certainly tested and measured, because we know that one approach does not work for everything. Certainly certain service lines, certain specialists that we're out there to introduce as part of promoting a service line don't always fit into that mold that you may have in mind for the tactics. So it's always important to sort of be able to look at that and then re-examine and identify places of potential opportunity or improvement. And then, of course, certainly looking at what the outcomes are, making sure that those reports that you have, the ability to look at where the activity took place within your team, overlaid with, are we seeing trends in growth or declines in outpatient migration because you've been able to solve issues. All of that are sort of feeding into that metrics of success and sort of keeping that system moving along in the right direction. So with that, I am going to hand it over so that you can take a look now at how Abby at Henry Ford has been able to take all of these pieces, put them into place, and really start to, sort of where the rubber meets the road and put it into action. So with that, Abby, I'll pass it over to you.
Great, thank you. So if we could take a minute, I think we did want to do our next poll at this point. So I believe we have a second poll coming up. Here it is. How are you currently driving your physician engagement strategy? A couple options again for you to take a look at. We're effectively and efficiently using actionable market insights for targeted visit schedules. We're implementing new processes, tools to automate and guide us. So we don't have much of a strategy. We visit whomever lets us in, or we just receive complaints and feedback and operate reactively. So please take a few moments and click about where you're at, and we'll take a look. Great. Oh, great. We're implementing new processes, tools to automate and guide us is the winner, which is fantastic. Spoiler alert, you'll be doing that forever along this journey. There's never really a true endpoint. There's always learning to go on, but it's great that so many of you are in that space. Next, effectively and efficiently using actionable market insights for targeted visit schedules. Amazing. That's really tremendous. And for those that don't have much of a strategy and you're operating reactively, well, you're in the right spot. We were there not too long ago ourselves. So thank you so much for taking the time to answer that and give us a better idea of where you're all at. So Keri, if we could go to the next slide, putting it in action. What I wanted to show you briefly here is a little bit about what Henry Ford has done and some of the tools that we've used to do this. So Henry Ford Health System has 5 hospitals and many offices, clinics, and outpatient centers across Southeast Michigan. To manage these areas, we've set our system into 3 major markets. So internally, we've set a north, south, and central market, and that's so that we can better identify and align our different bits of information and our leadership teams. Within these markets, our teams that specialize within market outreach then roll up into a system-wide team that shares best practices all across our system. Within our PRM tool, we've found that many different pieces fit real nicely for reporting and utilization in different layers. As shown here, you can see our outreach liaisons use the provider demographics and activity issues and logging portions of the PRM the most. We've built a team of analysts who work directly with our outreach liaisons and through our market leadership teams. These analysts pull and analyze the data from PRM, and they are right next to the leaders who are asking the questions, as well as the outreach team who are able to answer some of those questions by being our boots on the ground. The analysts then can sort of create conversation and discussion with their data. And then our leaders are really making use of the dashboards and the reporting to keep a pulse on what's happening across our system. These 3 teams work together to bring information and data into our planning, strategy, marketing, and outreach teams all across these markets, ultimately rolling up entirely into our system-wide team. It's a great tool. We've had a lot of wonderful discussions through this setup and this hierarchy. Next slide, please. I wanted to show an example of how our leadership team takes a look at the data in PRM. And within our larger markets that I just discussed, we do have identified smaller micro markets. And this is an example of our Northeast Metro Detroit micro market that includes our Macomb Hospital. We've utilized PRM extensively in this sense to gauge a baseline of volume and referring activity prior to COVID coming into Michigan in March. As I was saying earlier, we had a second surge in the fall, and we're now experiencing some reduced COVID caseloads. Luckily, that surge is starting to end, and our case counts are coming down very, very low, the lowest they've been since October, actually, so we're happy to report that. On the other side, though, our leadership team is saying, okay, where are our volumes? We're interested to see where we were pre-COVID and now post-COVID, and what do those numbers look like? And this is a sample of what we provide through PRM to create that discussion with our leadership team. Here's a sample of our orthopedic service line report our outreach team utilizes. This is sort of, I'm giving a bit of a drill down level of examples so that you all can see how this works. And the focus from this graph is that we have a great opportunity, as a majority of our orthopedics work in this particular micro market is moving out of network from Henry Ford. Midway on the slide, you can see the specialization and site of service where the encounters are occurring. And our outreach team and analysts use this trend to begin to drill down even further into specific practices and providers that we could possibly target to generate relationships or build on existing relationships. Of note here is that, as you can see, in March 2020, we did begin to see the sharp decline of volume and patient activity, and that was due to COVID. As you may know, the Detroit area, so 3 of our 5 hospitals were hit very hard when the COVID pandemic began in March. So here on this slide is a sample of the information collected into the provider profile. By collecting additional information as indicated in the blue, sort of near the bottom of the profile card, we can see incredibly helpful data about this provider, conditions treated, procedures performed, accepted insurances. Our teams use this group affiliation section also very often when slicing and dicing information and looking for updates on trending volumes. Another big way that I wanted to share that COVID changed how we use PRM at Henry Ford is through this provider profile. Outreach liaisons began to communicate very regularly with our providers and build upon the relationships that they had early on in the pandemic. They exchanged information. As many of you know, things were changing almost hourly in the beginning. And so our outreach liaison team was wonderful in communicating, who's open, who had open beds, how was testing, what was happening, different things to keep people safe, what was the latest from the CDC. So those communication lines were incredibly important during this time. A lot of it was so happy to find this out, but in our Southern market, many of our outreach liaisons worked with marketing and built pamphlets and provided materials to help inform physicians and practice offices. Henry Ford was instrumental in helping people get masks, cleaning supplies, understanding what they needed to do to keep themselves and their staff safe. Now we're on sort of the other side of this, and we're looking at vaccines, right? How do we get more shots in arms is what we're saying. And so that focus also, this line of communication that's been established has been instrumental in helping get our 1A healthcare staff vaccinated. And now those practices and providers are coming to us and saying, what's the best route for us to help get our 1B patients vaccinated? Do you have a line of sight into that? Our outreach liaisons are updating this information and sharing it with each other. And I think it's just a tremendous experience and understanding to see how data can also help with relationships and in a time of crisis really, really help everyone. What's another interesting thing is that although we realized that initially it seemed like the provider profile was not the largest part of the PRM system, it really has become a very integral part. The activity logging that accompanies this has been a huge part of the physician relationship, and our leadership really relies on this information.
And Abby, I think that it's safe to say that this information I know that you shared with us is critical, especially as you said, some of the services opening back up sooner than others as we shift to some elective procedures, but of course, emergent procedures and things like that. But knowing sort of where to go first, even as your liaisons are taking off that sort of sales and relationship building hats a little bit, in a sense, to offer up the services and the intel for the surgeons who are going to be coming back into the hospital, making sure that their patients are really comfortable, but kind of blanketing that whole that message, of course, is a little bit difficult. Having this information, I know you said was helpful in targeting where your priorities really were, right?
Exactly. So this next slide here looks similar to the previous one I discussed in regards to a market overview. What we've done here, of course, is focus a little bit more on the orthopedic service line and at the referral level. So here, our market view work comes from market intelligence on the platform, and we're taking a deeper dive. Through the PRM market intelligence module, we can identify how many PCPs are referring to orthopedics in and out of the Henry Ford network. And in this particular instance, we're using a smaller micro market. As you can imagine, this gives us great insight into which providers and practices we want to converse with, and we want to identify, build relationships, create relationships. Additionally, we can identify which practice or orthopedic provider is receiving the majority of the referrals in our targeted market. Again, another example of how we can begin big at the market level and shrink and drill down further and further into the data that then will provide tactics and some operational strategic moves for our teams. The outreach liaisons are really enjoying the data conversations. I'm a self-proclaimed data nerd, and so our outreach liaisons joke with me constantly about, okay, we're good. Let me think about this for a minute. But I really do feel, and just this morning in a meeting, they said this information has been invaluable to them. What's great too is that they can filter information back up then to the leadership teams. So we're having strategic conversations as well as, like I said before, that boots on the ground conversation that's so invaluable to our business. And this final slide is a small little snippet of information. But what I wanted to share with you on here is even though it's a simple listing, what we utilize it for is really important. It gives us insight into some specific subspecialties and particular market area. And I wanted to give an example. We've used this type of information in our central market area when looking at which specialty in which region and what providers may be a good fit. So shown here is referral volume, but we also have patient volume available. So for example, the questions asked here are, okay, well, we're not really interested then in maybe looking at another foot and ankle specialist, but maybe in our region, we should look at another hand specialist. So drilling down even to that particular level has been a wonderful insight for us. And so PRM overall has given us the opportunity to address these questions with data. And then in combination with that gut feeling and the word on the street has really been able to give us a better sense of who we need to discuss with, what type of planning and strategy can move forward, and how Henry Ford can move the needle forward overall through all of our relationships across the board.
And Abby, I thought of another question that I had for you too. When we talk about this sort of, I say downtime, but really what I mean is off the road time, right, for the liaison team. But are you finding that folks are coming to you more now, with these questions about the data because there's a little bit more time to focus on that, but also still capturing their interactions with providers and offices with the safety measures and things like that?
Yeah, you're so right, Keri. We've had a wonderful experience in some of our outreach liaisons wanting to know more about the market intelligence side, which typically is where our analysts sit. And instead of asking the analysts, they're saying things like, "Oh, please show me how this works. How can I learn more about the trending?" Or the great thing too is I think it has provided some space for thought, right? So a lot of our outreach liaisons, again, just this morning we had a wonderful meeting where they were giving us some great feedback and some great ideas on how we could use the system differently, some different reports to pull, some different comparisons that. Me being an admin and not out on the road, I don't necessarily have access to that information. So it was a tremendous conversation and really gave us some new food for thought to move forward and some different reporting techniques that we can utilize in the system.
And I know from, I'll just share some anecdote here. I know from my days of working as a liaison in a pretty large healthcare organization, I think what happens is you start to socialize these different insights that you can find from this data because one person asked, and maybe you produce for them some reports and dashboards of what the liaison team is doing out in the field. And as those continue to get socialized, you have more and more people starting to knock at your door, which is a great thing. I mean, sometimes that means you need to expand your team and have more folks to help you. But I know from my experience, sharing some of those reports and showing how we could be improving things and, getting myself on a monthly service line leader calendar so that we could go over trending issues and things like that. There's so much power in that. You're building credibility for the issues that you're resolving and the things that you're doing to help your provider community, but you're also building internal credibility, right? Now, especially as we talk about that whole source of truth concept, they're coming to you for this information, and there's such an opportunity to grow what you guys can do from the system and continue to show your worth to the organization. I think that's probably fair to say.
Yeah, totally. And Keri, one other thing that I think has happened along those same lines is our outreach liaison colleagues. We get together monthly and they discuss, because they're in different markets and different regions, they discuss different things that they've done, different conversations, data comparison models, and things that they've used and found success, and we're sharing it across. So now it's truly becoming a best practice conversation. And seeing that grow over the past year has been really rewarding for me personally, but I think our system is benefiting immensely as well.
That's great. And certainly keeps you guys top of mind for keeping this tool in front of you for
Definitely
a long-term strategy, right?
That's right. And keeps the stakeholders happy. So that's always a good goal too.
That was great, Abby. Thank you so much for sharing your insights with sort of, like I said, how you put this to action, because, you know, I could talk until I'm blue in the face about all the homework you have to do to get a good system in place and get a good curated data set and everything. But until we really have some, you know, conversations about what does this really look like? Where did we hit some bumps in the road? But where was it really successful? So with that, we definitely wanted to leave a good amount of time for some question and answer here. I know that some questions have been rolling in, and you know, this is such a wide topic, and folks are coming at it in so many different angles that we expected to have a good spirited conversation about it. So with that, I think I know that people have been submitting some questions as we go through. Just a reminder, if you haven't done so already, to submit that question, you can type it into the question and answer panel at the bottom of your screen at any time. So with that, I will pause there and see what questions we would like to tackle first.
Great. Abby, Keri, thank you so much. I know the audience really enjoyed this, and they've submitted a few questions for you guys. So we'll start with, could you please share more about the provider opportunity score? We're doing something similar right now, but all manually. We'd like to automate it as our directory grows. What type of factors do you begin with when building out the algorithm?
Yeah, that is a really great question. So this is a brand new feature of our more optimized version of the tool. And this is something that Abby is getting very familiar with too. So our provider opportunity score is taking into account 5 different factors. So they're looking at, when was the provider last visited? How many issues do they have open? What are their out-of-network referral trends? What sort of service line activities are they doing? And what it's doing is you're able to, the customer or the client is able to sort of decide where they want these different things weighted. So if open issues, for example, is a really important factor, we can weight that more heavily to feed into that opportunity score. If that's really not, then we can certainly, you know, sort of change the angle of them at any time. But what it does is it allows us to build a dashboard, for example, on a home page, so that as you know, as somebody on Abby's team logs in, their territory or grouping of providers, whether that's a geographic territory or a specialty-based territory, they can look now in order of where is there the most opportunity. So if somebody's got an opportunity score of 84, which is pretty high, we consider 100 to be the highest, then we know that there might be some opportunity there. So it also may be the type of thing that you look at and say, oh, we already know, we've already tried with this provider, he's very loyal to another competitor, and there's no sense in taking our time there. So that's how we have structured it thus far. Great question.
Great. All right, next question. Do you capture which docs have equity in freestanding facilities and which docs belong to ACO full risk contracting?
So I'll touch on this briefly, Abby. I'll let you speak to it too, because I know that this is something that that you guys have looked at as well. So we tend to encourage a client to sort of break out their provider network as they load them onto the platform as a binary designation of in-network or out-of-network, and that's up to Henry Ford, for example, to decide how they want that. But furthermore, we let them decide an affiliation. Are they aligned, just sort of loosely, or are they like more closely affiliated? And then another step we've taken is to allow for what we call provider program groupings into things like ACOs, CINs. Those are certainly critical pieces to approaches. So Abby, I don't know if you want to touch a little bit more on how Henry Ford has looked at that as well.
Sure, sure. Yes, it is an important piece in order to report out on for Henry Ford. And one thing that we've tried to do and are still working on is we do have a way to identify those particular pieces of information in PRM. But what we're finding is our information coming into Henry Ford Health System needs to be enhanced a bit more. So in order for us to fill the PRM with the correct information, we're going back and scrubbing through and making sure we have the correct information to put in. But to Keri's point, yes, all of those are available and we utilize as many of those bits and pieces as we can.
Great. You guys spoke of wanting to converse with referring physicians who are contributing to leakage. Where do you draw the line between merely conversing versus coercing, i.e. whether openly or between the lines threatening referring physicians in your system not to refer outside of the system?
Yeah, that's always a hot topic. So those of us who either are in the field now as liaisons or were, as I was, we're all well aware of Stark and anti-kickback statutes. So something we definitely need to be careful of. And we know that there are, it's a very fine line between, please know what our services are and that ours are best versus, true inducement. We've got to stay far away from that. So it's a really good question. I think there are ways to craft conversations with providers that are simply saying, I would never encourage someone to take a snapshot of the claims data like Abby showed today and turn it around and show a physician, because as I mentioned before, it's not 100% of the data. And we don't want them to make inferences that are inaccurate, that could be potentially harmful. So it's meant to be a storytelling piece. It's meant to be able to walk in and say, we know that you utilize our orthopedic services. We also know that you use our competitors' orthopedic services. We would love to get more information about what are we doing right? What are we potentially doing wrong? Just wanted to also make sure that you knew that we have a new orthopedic surgeon in our facility. And that's where it goes. And then you check in with them periodically, right? I mean, you go back a month later and just say, just wanted to make sure if you did start to utilize our services, how have things been going? And the other piece I always encourage teams to do is, especially if you are, taking out a new provider, for example, we know that liaisons frequently are taking out a new surgeon into the community, into the PCP offices and things like that. And even if you're not doing that in person, there may be some virtual meetings happening. Get some feedback from that specialist. I can't tell you how many times I would get stopped by our new general surgeon in the hallway that said, hey, that PCP office that you brought me to last week, I just got 4 new referrals from them this week. That is critically important information and something I'm not going to see in the claims data for several months, right? So take that information and go back to the office and say, hey, we just wanted to say thank you. We wanted to just see if there's anything that we can do to improve upon your experience with referring into this surgeon. And that's really where it's at. It's obviously certainly not paying them for doing it, not inducing. And even when it comes to medical group affiliations with an organization, you still can't, you can't insist that they continue to refer internally. So you just have to come up with ways to craft those stories, I think, in a creative way, certainly.
Great, thank you. Abby, I think I'll direct this next one towards you. As the self-proclaimed data nerd, what sort of results have you seen volume-wise after utilizing this data?
I'm going to assume that volume meaning users. We have increased our user profile on the platform significantly, so much so that at this point we're actually turning away some people. And that's where I really wanted to identify in this discussion that we came up with the idea to build an analyst team specifically. Each of the analysts are directed towards a particular market or region area, and they work directly with the hospital presidents as well as the market leaders. And they are also connected to the outreach liaisons. So that helped with the number of users on our platform. But it also helped because with knowledge share across the system, we are now not knowledge sharing, having meetings of 90 people, but having meetings of 10 to 15 people, and we're able to have much more developed discussions and understanding. And the North Market has developed something to look at that maybe might assist in the South, and so that connection is being made through that smaller team as well. I also tend to be a little more agile in my team building. So I like smaller work groups and smaller teams that can move a bit faster. So that was one of the other benefits of having an analyst team instead of just growing the user platform for as many people as possible.
Oh, that's terrific. All right, so the next question sort of, where do you start in a large system with multiple priority service lines? I mean, where do you even begin?
That's a great question. So a couple different avenues that my leadership has worked on. And, I'll be honest, at the beginning of 2020, in the last quarter of 2019, we had all these amazing discussions. We had these great plans and all of this was going to happen. And by the end of January, I think that was pretty much chucked out the window and things were completely changed. So we returned to taking a look at, as I said, we have our large market segments. Our planning and strategy team has worked into a micro market area so that we can further refine our look. And then we also have service lines that go across those markets. So where to begin? I would take any spot, really. It's sort of at this point, taking a bite of the elephant, right? Start somewhere, understand with your leadership what their focus is. In Detroit, at the Detroit campus, we just opened our new cancer pavilion down there. So that being in the capital project space was a very big motivator to take a look at the oncology side in that particular region and that particular marketplace. So we did some of that work. So aligning with our strategy and planning team is really important here. But it's also something that if you see something, maybe you can converse upward to your leadership and say, okay, here's some trends we're seeing. And with COVID, what we've been able to do, as I showed on a couple of the slides, baseline pre-COVID, and now we're taking a look at trending after. Because not only do we want to get back to those volumes, but we want to continue to grow as our strategy plan had indicated before the pandemic began. I hope that's helpful.
And one thing I'd love to just add to that, because, Abby, you made a really great point. You touched on the word leadership alignment. That is an ever existing battle, or certainly something to overcome. So I think when you think about, especially if you've got 5 different priority service lines in front of you, do some homework before you really start to, take a bite out of it, so to speak. So I think one of the critical pieces that I always found I had to do is get alignment on what are the goals, what are the metrics that we plan to measure, what are the KPIs, so that we know what's reasonable. What are they expecting out of my team as we go out there to try to talk about these services? The other big question is, are we operationally ready to take on more patients? Presumably that homework has been done already, but you'd be surprised. I've found myself in a situation where I was talking about a new orthopedic surgeon that we had, and when the practice manager told me that it still takes 6 weeks to get into our orthopedic surgery division, that was a little bit of egg in my face. It sounds like we weren't operationally ready to grow that business. So that's always a critical question to answer. And then the other piece of that also is not just is the service line operationally ready? Are you as an outreach team operationally ready to take this on? So when we talk about the best ways to break out teams, on the platform, as Abby knows, you have ways to create territories or groupings of providers, but what does your liaison team structure look like? Are they specialty based? I mean, I have a couple of clients that we work with who have nursing degrees. Some of their liaisons have nursing degrees in certain areas. That sounds like a great opportunity, of course, to break them out by specialty because they can really be clinically focused. But if you've got another group with a large footprint, for example, I've got a client that we work with that has a 4-state footprint. We know that they had to break their very small team up geographically in order to be effective. So I think it's looking at all of those pieces, looking at what are the goals that leadership is expecting? Are they ready? Are you ready as a team? And if not, if they're asking you to grow these 5 different service lines, make sure that they're giving you the right resources to do it. But also make sure that they know what you are going to produce from it so that we can, analyze and report out to the key stakeholders within the organization.
That's great. Can you talk a little bit about how outreach staff integrate with CIN outreach staff? Do they all use the same PRM?
So I know that some of our clients, what we do is we build out the platform and the ability to what we call log activities or log calls to any provider. We build it out such that if there are going to be different user groups, let's say like a CIN, outreach group versus your sort of standard liaison, we make it so that there is structure to the call logging that is appropriate for what they need to be collecting or asking. And I would say more often than not, especially if it's a larger liaison team, they are broken out for certain ACO or CIN initiatives, and they're capturing different pieces of data than the standard liaison might. So I think it's important to be able to report out on either or, but potentially also more from an overarching umbrella. So I think but of course, if you've got a smaller liaison team where you don't have that luxury of sort of separating out. Again, if that's something that leadership is going to be asking for, make sure you've got the system set up so that you can capture the level of detail that is specific to the CIN. If there are very particular questions that they need to be asking, or if you're actually recruiting into it, make sure that those are all pieces that you're capturing in those visits, in the visit detail, so that you can produce, really meaningful reports.
Thank you. All right. Are you guys still visiting offices despite the pandemic, or are you using Zoom for visits, or can you talk a little bit about how you're handling it?
Certainly, I can talk a bit about our team. They're doing both. There are some live in-person office visits still going on, some Zoom or virtual visits. A lot of information is being passed back and forth at this time, and it really has depended on the practice. Our outreach liaisons are working with the various providers and practices to understand where they're at in opening. Most of them in Michigan are back. I want to say about 100%, if not darn close. And so it was a great experience to understand and see our outreach team helping those practices become open, learning about patient safety, cleaning the office, and then how to communicate with their patients that, hey, we're safe, we're back, we're ready for you to come in. Please don't extend, please don't wait any longer for some of the services that you need. So we are, though, experiencing both. I think one thing that we're all learning, and we're still kind of in this space to understand, is the virtual visits were quite effective, right? So no one really wants to give them up 100%. And I think at this juncture, our team and all of us are learning how to. We don't want to go flip-flop all the way back 100% to in-person. We want to be able to utilize this virtual visit piece to its fullest potential as well, because it is awfully convenient. The providers have said, if I can sit in my office and talk to you and not have to worry about you coming in or me going somewhere, a lot of them have really preferred to do that. So I think, again, it goes back to that relationship and understanding the type of conversation you're going to have, because I know our outreach team has indicated certain conversations are much better in person, obviously. But some touch bases and some quick updates happening virtually have continued on.
Yeah, I think, Abby, you touched on a really important point, which I think is adaptability, right? I mean, I think we know that there are part of the population is getting more and more comfortable to be out and I'm even talking patients or providers. And some are not. So I think being flexible and adapting to both of those and coming at it with sort of a hybrid approach is a great idea. And I've actually talked with a couple of groups who shared some really great ideas too, which are, make sure that so when we think about the fact that so many people have started to use telehealth, of course, during this time, there's a definite shift in digital trust that's happening from the consumer and patient base, and probably also from the provider base, although they were closer than the consumer before. But keep in mind that folks are going to websites to get more information. So make sure that you're well aligned, if you can be, with your web team, and see what you could be embedding onto your website. So whether that's a section that's just for providers, perhaps doing a Zoom video of a CME event on there that you would normally obviously do in person. See if you can embed something in there and make sure you're driving physician traffic to that. And on the consumer side, if there are, educational sessions that your orthopedic surgeon can do and videotape and put on there, so that you are adapting and, still delivering to that consumer who's not quite comfortable going out in public yet, you're really kind of covering all your bases. So get creative, and keep that hybrid approach going. And things are going to continue to shift. Who knows? I mean, I hope we don't see another spike, but we need to just be ready for, anything that comes our way, right?
Yeah. If I could just add on one really neat story that I recently heard, and this is from an outreach liaison and a provider. They had decided to do a virtual meeting sort of after hours. So the provider was at his home and the liaison was at her home. And they said it was so much more conversational. They felt like they got to know each other better, the pictures on the walls, the books on the bookcases, those kids kind of coming back and forth in the background, the cat jumping up on the keyboard. They felt that environment really almost brought them closer together, and they were able to have a very individual and very positive conversation through that. And when I was listening to the story, I thought, wow, what a interesting time capsule story for us during this past year and a bit, right? Knowing that people have cats and things like that in the middle of a meeting, pre-COVID wouldn't have happened. So I do think there is some benefit there. And like Keri said, it's going to be a mix, and we're going to try and figure out as we go along what's most efficient. But I wanted to share that story because I thought that was very unique to our time.
Great.
Yeah, I think that's a terrific anecdote, and love to hear people adapting to the world we're living in now. I think we have time for maybe one more question and sort of building off of that. How do you guys figure out how to position a team and then break them out for the best efficiencies given everything that's going on?
Yeah, I mean, I touched on it briefly before, but I think that taking a real close assessment of what you have for team resources is the first place to start. I think, if it's sort of it's an approach of what do I have in front of me versus what do I need? And then as I mentioned from that one person's question about, having multiple priority service lines, where do you really begin? Make sure that you're getting a good sense, again, what they are expecting. So if it is going to be really service line driven and not just sort of, growing volumes across the board, then maybe you break out in a service line sense. So, when we think about having multiple liaisons on a team, we know that the one thing we don't want to do is be in these physician offices, stepping on each other's feet, having 3 different reps go in there during the week. We know that they still have to see pharma reps and things like that. But, keep in mind that if you're going to be broken out in a specialty sense like that, make sure that you can see you've got insights into when the last time your colleague was in there. So, of course, utilizing like a PRM system, you're able to look at, Abby was just in that office last week. I think I'll maybe skip this week and we'll go next week if it's not anything urgent. So, if you're going to break out by specialty like that, that's critical. There are certainly a large number of groups, I think, that break out instead geographically, because it just makes more sense for their footprint or, for what their initiatives are. That's a little bit safer in the sense that you almost have sort of ownership over your grouping of providers in a certain geographical territory. And then even more so, there are some that kind of do the hybrid approach. They might have the Northeast market and just orthopedics and neuro, whereas someone's got the Northeast market and they've got cardiovascular services. The key important piece is that you're talking to one another, you're reporting out on all of this, and everyone knows where everyone has been, so that there are no real silos happening. I think that is definitely something that you don't want to have happen, is have a provider feeling like they're more of a number. Make sure that relationship building piece is there based on whatever you have for resources and what's expected of you all.
That's wonderful. And with that, I think we've come to the end of our program. Thank you, Keri and Abby, for sharing your wisdom and insights, and this terrific presentation today. And thank you to everyone in our audience for taking time to join us today. Please note that if you've asked a question our speakers weren't able to get to, we will do our best to get a response to you. We'll also be sending out a link of the webinar recording. Watch for that within the next few days. That concludes today's program. We hope to see you at future forum webinars as well as the Healthcare Marketing and Physician Strategy Summit, October 6th to 8th in Miami. Please visit the forum website, healthcarestrategy.com, to learn more. Finally, be sure to give us your feedback by completing the evaluation survey as you exit the webinar. Thank you and have a great day.
Thank you.
Thank you very much.